Hello, everyone. This is Dr. Siddharth Tambar. Welcome to our webinar today. We're talking about regenerative medicine treatments for runners. Before I get started, if anyone who's currently live, either on Zoom or on any of our social accounts, please just indicate to me whether you can hear me loud and clear. Wonderful. Okay, great. So today's webinar, we are talking about the following. We're going to talk about regenerative medicine treatments that do not require surgery, specifically using treatments like your own bone marrow cells and your own blood platelets to treat various running injuries. Learn a little bit more about what is legitimate in the field of regenerative medicine, as well as how to choose the best physicians or clinics if you need a regenerative medicine procedure to get the best outcome for yourself. And again, after the webinar, if you'd like to learn more, you can always go to chicagoarthritis.com. After the webinar, you'll also get a copy of that can either be watched again, or you can share that with anyone who you think would benefit from this. So the big question is, what would you do if your pain was controlled? How would your life improve? What exercise would you restart? And what activities with friends and family would you start to participate in again? So a bit about me. My name is Siddharth Tambar, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology as well as regenerative medicine, specialist in image-guided musculoskeletal injections. In practice since 2008, involved in regenerative medicine since 2008, and part of the Regenix network, which is the largest network of affiliated physicians that are sharing best practices in regenerative medicine, and I've been in that since 2012. So traditional care for runners, if you have an injury or pain, essentially you stop running, take pain medications, brace, wrap, ice, acute injuries, basically masking the pain and eventually waiting for surgery. Throw in some physical therapy to hopefully get better, but really very limited. The problems with traditional care are pain medications don't fix the problem. They have potential side effects. And the traditional injections that are utilized, that include steroid injections and nerve blocks, really are not great for your body long-term. And they're not things that I would recommend for most of my patients. Surgery has a role in some cases, not in all cases, and actually very few cases. But surgery, if it's routinely done, has higher rates of various risks, including infection and bleeding, anesthesia risks, cardiac risks. If you are a runner and if you already have some early arthritis, and if you actually get, let's say, meniscectomy or quote unquote clean out surgery, what will happen is that you'll actually leave the joints slightly more unstable and you'll have more progressive arthritis over the next few years. Because of that, many routine surgeries are proven not to necessarily be effective in the setting of existing arthritis. And for those of us involved in regenerative medicine, strong belief that 80% of musculoskeletal conditions should be able to avoid surgery. In the same way that in cardiac health, what used to be handled almost predominantly by cardiac surgery, now 90-95% of that is handled with either needle-based procedures or medications. So in searching for better options, we want options where there's lower side effects and lower risk, where we can improve the actual cause of the problem, and where we can actually give you longer-term improvement.
This meeting is being recorded.
So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the practice of medicine where we utilize your own cells. We'll talk a little bit more about that to treat arthritis, tendinitis, injuries, and back pain. In a normal healing process, take something as routine as, let's say, a cut on your finger. You have platelets that infiltrate the area. Those platelets first stop the bleeding. They then release growth factors. That then causes stimulation of your local mesenchymal stem cells, which then coordinates bringing other cells, growth factors, that's inflammation, which then leads to a normal repair of the cells. So this works well for tissues that have really great blood supply, things like skin and muscles. For tissues with poor blood flow, they tend not to heal as well on their own. That can include tendons, cartilage, ligaments, discs, labrum, and menisci. Those tissues can be very hardy, meaning they don't tend to get damaged as easily, but once they're damaged or recurrently damaged, they tend not to heal very well. So regenerative medicine is the process of taking those same cells, your own blood platelets, your own bone marrow stem cells, other kind of growth factor treatments, and then injecting that into damaged tissue to coordinate a normal healing process in order to recover. So why regenerative medicine? We'll talk more about this. Treats the source of the problem, which is instability as well as inflammation. Safer than surgery, effective for most musculoskeletal conditions as well. So how does regenerative medicine work? In a few different ways. To begin with, we can optimize damaged cellular tissue. So by injecting your own cells, your own platelets, your own bone marrow cells, we can assist damaged cells in the tendon, joint, ligament, or nerve to work better. In addition, we can also improve the strength and stability of supportive soft tissue structures. We can do that by essentially in a chronic arthritic issue or after an injury, what you have are a lot of soft tissue structures around the joint that have been chronically weakened. And by strengthening those supportive tissues, which we're able to do so with Regen Med treatments, we can not only reduce chronic inflammation there, we can improve stability there as well. That improvement in stability helps with pain relief long-term, as well as with function. And so previously damaged cells that are no longer functioning normally, they're not pumping out the right proteins and enzymes, by stimulating them, getting them to work better, they start functioning better. They are now pumping out the right proteins and enzymes. What that does is it leads to a joint that is healthier as well, so less inflamed. In addition, by injecting your own bone marrow stem cells into tissue that's been damaged, you can get the existing stem cells in that area to start functioning better as well. In addition, by doing all that, by improving the cellular health, biologic health of a joint and the cells there, you'll get less inflammation in the joint. The cells are no longer pumping out the wrong kind of enzymes and proteins that are causing inflammation. They're now pumping out the right kind of enzymes and proteins. So you have less inflammation in a joint and a tendon. In addition, we can also treat the nerves and muscles around the joint or tendon that have been injured. By doing that, you can reduce pain and inflammation in the nerve. And in addition, frequently we'll actually end up treating the lower back as well if you've got lower extremity issues. And by improving stability in that area as well, you can actually improve overall pain as well in the legs. So what makes a regenerative medicine expert? There's a lot to this slide, but I'll just kind of go through it quickly. Essentially, your physician should be a musculoskeletal expert. And what that means is that they should be someone who's treating musculoskeletal issues day and night. They're not treating somebody's high blood pressure, erectile dysfunction in one room, and then running in and treating your knee. That's not an expert. The way medicine works is that to be an expert in a field, you have to be very focused and really only do that. And that's what makes a musculoskeletal expert. In addition, they should be a non-surgical musculoskeletal expert. Our orthopedic surgery colleagues are very well trained on surgery. The thing is that to do these kind of treatments correctly, you need to be an expert in image guidance for procedures. And that's not something that they typically get trained in. So image guidance, meaning high level of ultrasound and x-rays for all procedures. Your physician should never just be palpating the skin and then sort of blindly injecting, hoping to hit the right target. With these kind of treatments, when you're injecting your own cells, you can't be close. You have to be directly on the area that's damaged. You have to be down to the sub-millimeter to make sure you're hitting it. I'll show some pictures of what that means. In addition, your physician should understand how inflammation works. What I mean by that is a lot of our colleagues will end up using steroid injections to help treat an area. And the problem with that is it's not healthy for the tissue. And if you don't understand how to reduce inflammation long-term, and if you don't understand that acute inflammation after an injury is actually helpful for the tissue, you can end up getting worse by getting steroid injections. So understanding inflammation works is very key here. They should also understand the different types of biologic treatments that are available. I'll discuss that in a little bit. They should give you a very personalized treatment plan. It shouldn't be that they're using the same product at the same concentration of product for every single patient that comes in just because that's what they have in the office. It should be one that's personalized to you. I'll talk about that in a bit as well. They should understand the concept of prolotherapy and instability. I'll show some examples of that. They should be very transparent about results and your candidacy for treatment. Very key. They should follow your results long-term. It should not just be that they do a procedure and don't ever see you again. And they should be experienced with this. They should not be new to them so that they can guide you through the process. So it takes a lot to be a proper expert in this. Some common questions that I get. Number one, is this legal? And the answer is yes, if you follow the strict guidelines from the FDA. What that means is you have to use your own cells, not somebody else's. Your cells cannot be significantly altered or adjusted. There's some very strict guidelines to that. And it should be treating musculoskeletal orthopedic tissue. It should not be treating other things. We're not talking about treating things like post-stroke. We're not talking about treating chronic heart problems, kidney problems. We're talking about just treating joints and tendons and chronic back issues. Another question, if you're older, should you be using someone else's cells? Strict answer is no. For the vast majority of orthopedic conditions, there's good evidence that using your own living cells is still very effective. If you use somebody else's living cells, there are some risks to that. In fact, in the United States, injecting someone else's living cells into yourself is considered illegal. The exception is if certain childhood leukemias. And so really, this is strictly about using your own cells. Is there an age limit? No. The one exception is hips, where that can be worse as you get over the age of 65. But everything else, there's good evidence that even as you age, you can still respond to your own cells. Again, what sort of doctor does these treatments? As I mentioned, they should be a musculoskeletal expert, non-surgical expert, and they really should be an expert in all things regenerative medicine. Can these treatments help if you've already had surgery? If you've had a joint replaced, you can't treat the hardware. But if you've had, let's say, prior arthroscopy or spine surgery, yeah, these treatments can still help for sure. And that's because you can optimize the tissue that's still there. You can't necessarily reverse what's happened over decades of prior surgeries, but you can optimize things to get as good as it can be. So my general rules for patients who are thinking about orthopedic surgery is, as much as possible, try to keep your own anatomy if possible. Avoid surgeries that are just cutting out tissue. Again, some exceptions. Always consider regenerative medicine treatment option if you've been recommended surgery. Might still be an option if you're in that case. By the way, I do see questions coming in. We'll make sure to answer these as we go along. So in terms of regenerative medicine concepts, a couple of really key ones to make sure you guys are aware of. Stability is a very key one. There's this concept in architecture called biotensegrity. That means is that if you have individual units that separately are very weak, if you put them in close approximation and compress them, you have a much stronger overall unit. So this applies in the body as well, and that's called biotensegrity. Prolotherapy is the idea of injecting your own cells into the soft tissue structures around a joint or tendon that's been damaged. By doing that, you get a stronger overall joint area, which then leads to better stability, less pain, better function. The keys are to treat all the layers and depth of treatment. When you look at this under, let's say, ultrasound or in a cadaver lab, what you realize is that all these tissues are layered on top of each other, and each one of them gets damaged over time. So let's take, for example, someone's knee that could be injured. If, let's say, a meniscus is injured or you've got some early arthritis, well, you want to treat not only the arthritis, the meniscus is right in the joint itself, You then want to treat the medial, let's say the ligament right on top of it, the tendons on top of that, and then even some of the myofascial tissue or even nerves as well. So there's layers and depth of treatment. This leads to progressive strengthening over time and longer lasting results. So really important in runners to understand that there is a kinetic chain here from the lower back to the hip, the knee, then the ankle and the foot. And so let's say you're coming in with a knee issue. We need to be looking, hey, is there something that could be going down at the ankle that could be causing instability at the knee? Is there something possibly happening in the back or the hip that could be also driving knee pain as well? So this is an example, iliotibial band case. A lot of people, this is a 55-year-old man with right hip pain. He's been told that he has iliotibial band syndrome. So a lot of people who are runners in particular are told that they've got iliotibial band pain. The iliotibial band is a stretchy connective tissue that starts at the side of the hip, goes all the way down to the knee. And usually what you see people doing is they're just kind of rolling it out, right? Just constantly trying to compress it and help out with that. In this individual's case, what he actually has a pinched nerve in the back. He actually has a disc bulge that leads to a pinched nerve in the back that then leads to weakness in his gluteus medius muscle, which then leads to the IT band having to overcompensate, and that's why he's got pain on the side of the hip. So the MRI picture on the screen, I'm not sure if my pointer is working here or not, but essentially where that yellow line is, there's a disc bulge right there. That's what's compressing his nerve. The X-ray picture next to that is an X-ray picture of me injecting into his epidural space at that L4 level, his own platelet growth factors, and then injecting also the ligaments to strengthen that structure as well. And what he has is as follows. So his picture, his MRI picture before treatment is the one on the left. Again, there's a disc bulge there. His MRI picture on the right, now there's no longer that disc bulge that's compressing on the nerve. So his pain relief after treating the lower back is 80% better. His IT band symptoms are improved. He's back to running at his usual mileage, doing great. Great example of how, what's happening at one level can affect what's happening at a lower level as well. Orthobiologics, these are the cells and tissues that we inject into damaged orthopedic tissue. Again, this uses your body's normal healing process. Please use your own cells, not somebody else's. That's what's legally allowed in this country. Platelets, that's really the first line option that we talk about for orthobiologics in this country. After an injury, again, talked about how platelets help to recruit other cells and repair tissue. Uses focus inflammation to start that. And again, platelet growth factors help to stimulate your local stem cells. This picture on the right, there's different types of platelet preparations. So this picture on the right, you see the test tubes with the red colored serum. That's a platelet concentration with a lot of red blood cells. That's very inflammatory. I would not recommend injecting that into the joint or tendon. It'll be more painful, may even be damaging. Helpful for muscle issues, so still can be helpful. The one on the left, which are your platelet-rich plasma without the red blood cells, much healthier for the joint and the tendons. So this is important because the way that we make your platelets depends on what your issue is. If you have a primarily joint issue, we'll make a very high concentration of your own platelets, 14 to 20 times concentration. If you've got a tendon issue on top of that, we'll make like a 7x concentration. And if you've got a nerve issue, we'll make what's called platelet lysate, where we take those platelets, crack them open, take the growth factors and inject that into the nerve. So important to understand this because if your physician just has a little bedside centrifuge in the office and everyone gets the same treatment, regardless of what your issue is, you're not getting the right kind of treatment. The right way to do it is to have that level of flexibility that I just described. So next case study, this is of a 45-year-old triathlete, does a lot of running, presented with left knee pain. He was referred to me by a sports medicine doctor. His MRI shows patellar tendinitis. The picture on the right, again, I'm not sure if my cursor is working here, but that's the patella, that's the patellar tendon, and there's some little spurring there. That is patellar tendinitis. So in his case, we treat him with PRP treatment 2 times over about 3 months. The picture on the right, you can see that long kind of needle-like structure. This is a very zoomed in picture, injecting directly where the patellar tendon is injured. He got back to his full activity, doing fantastic. 3 years later, I saw him again. Now his other leg was a problem. At this time, he now had a hamstring injury. and again, utilize platelets, and again, doing great again, back to full activity. What's nice about this case is that platelets are great, especially for soft tissue injuries, and great how you can reuse treatment as well and get a better response, and how you can repeat treatment years later and get a good response as well. The next orthobiologic treatment to be aware of are using stem cells. Again, these are the main cells that help to drive tissue repair after an injury. Again, please use your own cells, not somebody else's cells. Very, very key. From a legal standpoint, that is what's allowed in the United States. That's also what is safe and been proven to work as well. And in addition, in the United States, you may hear a little bit about people using bone marrow stem cells are the primary legal way to utilize stem cells in this country. You may hear people utilizing things like fat stem cells. Those are not considered legal in the United States at this time to be used, and it's because there's a chemical, an enzyme that's utilized that the FDA thinks is not safe to use. You can use fat for structural support, so we'll use that for, let's say, a tendon augmentation as well, but we're not really primarily using it for stem cells. You may also hear about people utilizing things like amniotic and umbilical cord cells. Please understand that there's very little evidence that these work well for orthopedic issues. You may also hear about exosomes. Again, very little evidence. It's an interesting idea, but you can get those same growth factors from your own bone marrow or platelets. Please use your own cells. IV stem cells, you may hear about this in other parts of the world. No proven benefit for orthopedic conditions. That's been published in the peer-reviewed literature. May be helpful for inflammation, but again, I'd recommend using your own cells and just directly injecting it into the tissue that's damaged. So what about stem cell treatments in advanced cases? Let's say you've got more advanced arthritis. So we can still improve pain and function even in advanced cases. We can do that by improving stability, reducing inflammation, by getting your cells to be optimized and functioning as well as they can, improving your exercise tolerance as well. Keep in mind that we cannot necessarily reverse what your imaging looks like in that kind of case. Now, if you've got some swelling in the joint or in the bone itself, that can actually get better, even in advanced arthritis. But I cannot take what you have now and get you back to where you were 20 to 30 years ago in terms of imaging. But if your goals are, can you get back to a high quality of life because your pain is controlled and you're able to do more physical activities, yes, we can do that. If you've got a tendon tear, even a full thickness tear, if it's less than 2 centimeters, we can still improve that. If you've got a ligament tear, I'll show a great example of an ACL case, we can improve that. And even if you've got avascular necrosis, which I'll show, we can improve that as well. This is an ACL case. This is where the ACL is a major ligament in the knee that helps to support your knee stability. So we can definitely treat partial tears, all right? And again, if your tendon or ligament is normally like this, a partial tear, you've kind of got like part of the tendon has been torn or ligament's been torn. A full thickness one is where it's torn like this, all right? Now, if the tendon or ligament's fully pulled apart like that you need surgery. Although it'd probably be good to augment that with your own stem cells afterwards. But if it's fully torn but still closely approximated, we can still treat that, absolutely. I'll show you an example. So this is a 28-year-old runner. He's a butcher, but he's a 28-year-old runner. He tore his ACL, treated him a couple months later. By 3 months later, no pain, restarting dynamic activity. And I'll show you what his actual imaging looks like. Picture on the right, this is an X-ray image of the knee. The long needle-like structure is a needle going into the joint. And the structure that's highlighted up there is the ACL. You can really only do this using high-level X-ray guidance. Can't do it with ultrasound, definitely cannot do it blindly. So this is a great example of what's possible with these kind of treatments. So this is his pre-treatment MRI on the left. Again, I don't think my cursor is working, but in the middle, what you have is an ACL that's very disorganized, that's been described as fully torn. On the right side, you have an ACL that is now very normal looking, linear looking, and basically has been described as back to normal by the radiologist. So not only a great improvement in pain and function, back to full activity, but an amazing outcome as well with imaging as well. And that's very exciting. Actually, before I go on, let me just catch up on some questions here because I know that they're starting to pile up. Okay. So somebody asking about lower back issues, lumbar disc pressure on the nerve radiating to the right hip. That is incredible. Like I think I just gave an example of that kind of case. So absolutely, we can definitely treat that. Obviously, need to review the MRI. Need to talk to you as well, but that's definitely treatable. Oh, thank you very much for the feedback. Happy to hear that the wrists are doing well after treatment. Will inflating okay? So good question. So asking about injecting into a disc. So I do not recommend routinely injecting into a disc. Injecting into a disc, there's a little bit higher risk. We don't have to do that necessarily in most people. In the vast majority of people, if you inject into the epidural space and the ligaments that support the disc and the spine, that is more than good enough to improve things. There's a little bit of higher risk of injecting into a disc. It's not because you're inflating the disc per se. It's just that there's a little bit higher risk for infection. So we don't recommend that first line, but still very treatable. Somebody else asking from start of the process, how long can someone start to notice improvement? Good question. So what you'll expect after treatment, whether it's platelets or bone marrow, is that you'll have more inflammation for the first 2-3 days after treatment. By inflammation, I mean that you'll have more of a sensation of swelling, warmth, more discomfort for a couple of days, stiffness for about a week or so, and then slowly getting better. You should be noticing more significant improvement at the 1-month mark and then getting better for the next several months. For platelets, you'll have progressive improvement for the next 6 months. For bone marrow stem cells, you'll have more improvement for the next 12 months and further out. At some point, you'll hit a plateau. If you're at your goal and doing well, fantastic, nothing else to do. On the other hand, if you're maybe halfway at your goal, we'd recommend doing a repeat treatment to kind of get you to a higher level then. Another question, someone asking about someone who's got auto injuries as well as severe osteoarthritis and rheumatoid arthritis. As with everything, need to review the case in more details. If the rheumatoid arthritis is severely active, would recommend getting that under control first. However, if that's under control and what you're dealing with is now more chronic instability from the auto injury as well as wear and tear arthritis, that is still treatable, right? In terms of improving pain and improving function. So good questions. So kind of put in this slide in because it's kind of a question that sometimes people ask, long-time runners, is running bad for the knee? And the evidence is essentially that, number one, running has tremendous health benefits for most people to do it. For some runners, the knees can, the knees just, they can take on, it's too stressful in the knees. And you have to sort of play it by how does it feel to you? But for other people, their body adapts. The muscles adapt, the cartilage adapts, and they're okay to continue to run long-term. My dad is an example of that. He's 79 years old. He still runs marathons. He's okay. The signs to me that you should rethink that or get evaluated would be, number one, do you have pain? Number two, do you have swelling after running? And number three, do you have any signs of knee instability? That means it feels like it's giving out on you, starting to feel weak with activity as well. That can be another way that people describe that. But it's not a simple answer is running bad for the knee. For some people, it's perfectly fine. For other people, you have to be cautious and you have to take it on a case-by-case perspective. Another question I get a lot is, can we treat bone-on-bone arthritis? So the simple answer is yes. Arthritis is a biologic condition and it's treatable with these kind of orthobiologic treatments. If your range of motion and function are still good outcomes are definitely possible. In particular, knees definitely still respond very well to treatment, even when people are told that they've got advanced arthritis in the knees. The caveat to this would be, number one, if we're talking about advanced hip osteoarthritis, I would recommend surgery at that point. In addition, if you've got advanced arthritis, let's say in a knee, understand that our improvement, we cannot necessarily get your imaging to look like what it did when you were 18 years old. But we can improve your pain, we can improve your function, we can keep you active, we can keep you healthy. So still very treatable, some joints. Interventional orthopedics, this is the field of medicine where we're talking about injecting into damaged tissue. So I'd shown these pictures previous. The picture on the left is an ultrasound image of injecting into a patellar tendon that's been irritated chronically. Picture on the right is injecting into a knee joint where the ACL is torn. Again, good pictures there. This is a case study of a man who's got ankle avascular necrosis. Avascular necrosis is where the bone gets damaged, loses blood supply, starts to die off. Very important because your cartilage on the other side of that bone tends not to have very good blood flow on its own. It gets nutrients from the bone underneath, the subchondral bone. And so if you've got avascular necrosis, damage to the bone, what can happen is eventually the cartilage starts to get more damaged. So this is an individual who had his own bone marrow cells injected into the joint, the bone, and the ligaments. His image on the left is a pre-treatment image where you have not only a little bit of swelling in the joint, you also have some signs of avascular necrosis, all right, at an early stage. This picture on the right, he's doing great from like a pain and function standpoint, activity standpoint, and his MRI now shows that the swelling in the bone has resolved. Exciting because that is going to preserve the cartilage long term. So not only is he doing well from a pain and function standpoint, but we're kind of also giving him the potential to also do well long term as well. Regenerative medicine treatments offer safe and effective solutions for your pain. Just jump back over to some of the questions here. Okay, someone asking about can we do these treatments while you're on immunosuppressants? Great question. In my practice, I see a lot of patients who are on immunosuppressants as a rheumatologist. And what I find is that as long as you're on minimal to no steroids, you can still respond well. So if you're taking a chronic medication, disease-modifying treatment, biologic treatment, yes, definitely still treatable. Again, make sure your overall autoimmune condition is controlled. If you're on like a high dose of prednisone, not the right time for treatment. Would recommend that you get your underlying autoimmune condition under control first with non-steroid treatments, and then consider an orthobiologic treatment for what's remaining. Just a reminder, after we're done, if you have any questions, you can always go to chicagoarthritis.com and contact us. Is this too good to be true? So there's evidence, there's quite a bit of evidence over the last 30 years now. I had colleagues who maybe 10 years ago would say they didn't think these treatments worked because they didn't actually know the data. And now they'll tell their patients they're not sure, but they're willing to try, but still they don't understand the data. So Philip Hernigue is a French orthopedic surgeon doing these treatments since the mid-1990s. He's got great data for shoulders and knees. The Regenerative Network, we have data since 2005. This is a rapidly developing field, but it's not new. I have personal experience since 2008. There's right and wrong ways to do this. Work with a physician who knows what they're doing. This should not be new to them. This should not be something that they're doing on occasion. It should be something that they're doing every day, all the time. Your expectations should be grounded in reality and evidence-based medicine, right? Your physician should guide you through this properly. They should not be giving you recommendations like it's a 50-50 toss-up. They're not sure. That doesn't really make sense if you look at the data. You know, is there what is an average improvement that someone can expect? Is someone a good, fair, poor candidate? They should be able to tell you that. So how long do the results last? So Philip Hernigue has data that goes over 20 years. Regenerative has data that goes over 15 years. For a chronic condition, what I tell people is expect repeat treatment at some point. So if you're getting, let's say, just platelet treatments, you'll probably need, depending on your problem. If you have, let's say, a chronic arthritic problem, you'll probably need a repeat treatment in 2 to 3 years. If you're getting bone marrow, you may need repeat treatment in 5 years. Best ways to maintain your results after treatment: improve your biomechanics, work with physical therapy, improve stability by improving strengthening, take the appropriate supplements for inflammation, and then repeat treatment, if done, is additive to the initial treatment. What's nice with these kind of treatments is that they tend to put people at a higher, if you're starting down here, they tend to put people at a higher level for some time. If you start to fall back a little bit, or if you're repeating treatment at that higher level, you're now stair-stepping to a higher level after that as well. That's different than, let's say, a steroid injection where you get improvement right back down to baseline. These treatments slowly improve and keep you at that higher level. Cost, this is not routinely covered by insurance. Someone had asked about Medicare, not routinely covered by Medicare. There are about 3,000 companies that are currently covering this in the United States. If you're interested, to see if your employer is possibly covering this, or if you want to see about having your employer add this, please go to regenexcorporate.com. They can walk you through that. Otherwise, cost estimates in the US, costs are all over the map, but this is kind of what to expect. This is on average. Platelet-rich plasma typically starting at around $2,700, and using your own bone marrow stem cells at around $7,000. The keys to determine value. Number one, is your physician and the clinic, are they proper regenerative medicine experts? Again, would not recommend seeing someone who is not an expert in what they're doing medically. It's your body. Work with someone who knows what they're doing. In addition, make sure you're getting a real stem cell treatment, not something that's mislabeled like amniotic or umbilical cord treatments. And understand these are in-office procedures, so you can avoid hospital and surgery facility fees that can really drive up your costs as well. A bit more about us here at Chicago Arthritis and Regenerative Medicine. We're focused on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. Always starting with the big picture evaluation. What about inflammation, instability, asymmetry, neuromuscular issues? Always recommend treating with low-risk interventions if possible to begin with. If that's not working, then considering a regenerative medicine treatment option, if appropriate, utilizing the best products possible from your own body, a plan that is specifically tailored for your issue, a bespoke plan, and injecting those cells using the highest level of image guidance possible, including X-ray and ultrasound guidance. How to get evaluated, you can go to chicagoarthritis.com. You can email us, you can call us, send us a message via social media. We are available. Wonderful. Well, everyone, I appreciate your time. We're coming to the end of our time here. If you have any other questions, please contact us. Please keep in mind that we'll also send you an email with a chance to rewatch this or share with friends, family, or colleagues. And if we can be of additional assistance, please let us know. Until we connect again, I hope everyone stays healthy, stay safe, and live well. Bye-bye.